Well, welcome and good evening, everyone. Thank you so much for joining us for another Wellness Webinar Series event with Jefferson Health. My name is Sarah Breckbill, and I will be serving as your program facilitator and will present your questions to our panel of experts. This evening, you'll be hearing from internationally renowned experts at Jefferson Health. The panel of speakers will explore the latest research-driven innovations in spine care, including advanced surgical techniques, non-surgical therapies, and rehabilitation strategies for recovery. As the region's leading provider of spine care, Jefferson Health treats more spine patients than any other system locally and is nationally recognized for pioneering research that drives treatment breakthroughs. Well, thank you so much for submitting your questions in advance of tonight. And the questions that you'll hear me asking the providers are all submitted right from when you registered for this webinar. If you have any questions that come up throughout our discussion tonight, for those joining us on your computer or tablet, at the bottom of your screen, you should see an icon that says Q&A. We'll do our very best to get to as many questions as possible, but may not be able to answer all of them during this virtual event. And due to hospital guidelines and privacy, we are unable to comment on specific cases. Well, with that, I want to go ahead and introduce our experts for the evening, starting with Dr. James Harrop, Director, Division of Spine and Peripheral Nerve Surgery, Dr. Daniel Franco Martinez, Neurosurgery and Spine Surgery, and Dr. Amelia Nee, Physical Medicine and Rehabilitation. Well, thank you all so much for joining us. I know we have a lot of questions to get to tonight, but first, I will give each of you a minute or two to just say hello. You can provide a little background information about yourself, and then we'll get into it. So, Dr. Harrop, let's go ahead and start with you.
Well, thank you for having me, first of all. And what a great panel we have. Hope to have a great hour together with everyone. My name's Jim Harrop. I am a Jefferson through and through. I went to medical school here. I've been at Jefferson for over 30 years, which doesn't sound like a long time if you say it fast, but I'm getting old. And we're here for you. So whatever you guys would like to ask, we're hoping to serve as a vehicle to get you better care.
All right. Well, thank you. Thanks so much for joining us. All right. Up next, Dr. Franco Martinez.
Hi, good evening, everyone. And to echo Dr. Harp's comment, we're very happy to be here tonight. We appreciate the time and dedication of putting this together, and we're hoping to help answer a lot of questions and clarify a lot of things for our patients. My name is Daniel Franco Martinez, and I'm a neurosurgeon at Jefferson Health, and I subspecialize in treatment of all types of spinal disorder in addition to general neurosurgery. And similar to Dr. Harvey, I did all my training at Jefferson, including residency and fellowship. And I am based out of the Jefferson Einstein system mostly, that covers North Philadelphia as well as all of Montgomery County. On occasion, I'll also be in Jefferson main campus in Center City as well. Again, thank you for the invitation.
Absolutely. Thank you. All right. And last but not least, Dr. Nee.
Hi everyone, Amelia Nee here. Thank you, Sarah and team, for having me and for hosting this whole event. We hope it's really helpful for everybody and we can all learn a little something tonight. And I, unlike my co-presenters, didn't do any of my training here, actually. I did residency at WashU, Washington University in St. Louis, in physical medicine and rehabilitation, and I completed my interventional spine and musculoskeletal medicine fellowship at the University of Utah. So I am based out of Jefferson Bucks and Abington.
All right. Well, thank you to all three of you for attending tonight. I know we have a lot to get to and a great discussion ahead. So let's, without further ado, jump into it. So for the first question this evening, Dr. Harrop, you are going to kick us off. Is surgery always necessary for severe spinal stenosis?
So that's a great question. I'm glad you're starting out at the bottom, and we can only go up from there here. But just to go through, we in medicine love to throw this different words out for the exact same thing. So I'm going to try to bring this down a little bit. The word stenosis essentially just means closure of a hole. And so when we say stenosis, people commonly think of the neck or the low back, but it can be anywhere in the spine, and actually could be any vessel, such as carotid stenosis. And so we do this to confuse you. No, no, seriously, is uh, what you have to step back and ask yourself is, what is my specific problem and where is my stenosis? It's very classic to have two major areas for stenosis. And I feel like I'm on Jeopardy, so I only have 3 minutes here, so I'm going to go through this quick. So in the cervical spine, we call the cervical or the neck, we call cervical stenosis. The problem, and this is the big picture for everyone at home, your spinal cord, interestingly, doesn't have a lot of pain fibers on it. So when you have pressure on your spinal cord, you lose neurologic function. And typically, from a surgical point of view, we like or we think you should get your spinal cord decompressed because once you lose function in the cervical spine, it doesn't return. Now, don't forget, I'm making huge generalizations here. Same thing in the thoracic spine. The great thing about the thoracic spine is you have your ribs and you don't have a lot of motion. So thoracic stenosis is very uncommon. And the last piece, which is very common, and if I always tell my patients, because I work in South Philadelphia, is if you go into any supermarket in South Philly, you'll see all the elderly people leaning over their shopping carts. That's classic lumbar stenosis. Now, the great thing is life is about how good your quality of life is. And so in your lumbar spine, you're not going to go paralyzed. And interestingly, you don't get typically bowel or bladder problems from chronic stenosis in your spine, in your lumbar spine. And so most lumbar spine stenosis we can treat non-operatively. And it really comes to the point of, hey, how you doing? How far can you walk? Are you happy with what you can do? Because really, when I always tell my patients, it's not about me, it's about them, and it's about what their goals are. And you got to bring it back to what you want in life. So I heard a ding.
I think that was great. Thank you. Appreciate it. All right, let's move on to the next question here. Dr. Franco Martinez, this one is for you. Are there surgical treatments for leg and foot symptoms caused by lower back problems seen on an MRI?
Yeah, absolutely. When leg or foot symptoms are coming from your lower back and we can see the cause clearly on an MRI, there are several surgical options that can help depending really on what's going on. Some of them ranging from being very simple to some others to being really complex. Usually, these symptoms, things are pain, numbness, tingling, or some weakness down the leg, usually come from a pinched nerve in the lumbar spine. That pressure can be caused by either a herniated disc, bone spurs from arthritis, or generalized spinal stenosis, which is narrowing in the spinal canal. When conservative treatments like medications, physical therapy, or injections don't bring lasting relief, surgery then at this point becomes an option. And the goal is very simple, just to take the pressure off the nerve to give it the best chance of healing. Um, there are a few common types of surgery that we can use for this. The most common lumbar spine surgery that's done in the United States is a lumbar microdiscectomy. Uh, it uses a very small incision, oftentimes a microscope. We remove a very small portion of the disc that has herniated. I usually tell my patients, imagine a jelly-filled donut and just a little bit of the jelly came out and it's pressed pinching on your nerve. So we see that on the MRI. We go in, we take that little piece of jelly that came out, and that's it. So you usually keep about 90% of your disc or more, and it's usually an outpatient procedure versus maybe staying one night in the hospital. Now, if you have generalized spinal stenosis and the whole spinal canal is really narrow, then you can do what we call a full laminectomy, where you remove a little bit more bone to create space and decompress the rest of the nerves. In some cases, you may also need to do a spinal fusion, which, obviously it can be a scary word, but um, all that means is that perhaps additional decompression and shaving of the bone spurs might be required. And, if we don't stabilize the area, it can leave it hypermobile, and that can cause issues down the line. And so we stabilize it using implants. There's also newer minimally invasive techniques that allow us to do all these surgery through very small incisions, which usually means less muscle disruption, easier recovery. less pain. Not everyone qualifies for those, so we're happy to offer the whole breadth of neurosurgery and tailor treatment to each patient and their symptoms and what will give them the best chance of recovery. And so, the key point is this: surgery is never the first step, but when it's needed, it can be life changing. Like Dr. Harp was saying, it all depends on how you feel. What are you looking to get out of potential surgery, and being clear on, the challenges that surgery might present and how are you going to overcome that, or what the expectations are. Patients who've struggled with leg pain or weakness for months can often notice immediate to close to immediate relief, but it's a bit hard to gauge how that's going to respond, especially in situation where the symptoms have been ongoing in a chronic way.
Okay. All right, thank you. Well, we talked a little bit about surgery here. Let's talk about non-surgery options. So, Dr. Nee, I'll turn to you. Are there non-surgical treatment options for sciatica caused by bulging discs?
Thanks, Sarah. Absolutely. So, like Dr. Harrop had said, we sometimes use different words to describe the same things. People generally say the word sciatica. Medically, we say the word radiculopathy, where nerves are getting pinched in specific locations. So, it's basically one and the same thing. It's not specifically the sciatic nerve usually. Anyway, there's a lot of different modalities and a lot of treatment options that we can use. I think Dr. Franco Martinez hinted at it, but always starting with physical therapy. Motion is lotion, and exercise is really helpful. Specifically, it's about strengthening and stretching to restore like your muscle balances, improve your posture, restore and support spinal stability. And then sometimes the PTs will even use things like neurodynamic mobilization, which is basically like nerve flossing to help nerves be more mobile and be more flexible. Um, we can also use medications, so nerve membrane stabilizers like pregabalin or gabapentin. That can be really helpful to address symptoms to, again, help you be able to do the physical therapy you need to do. And there's also epidural steroid injections for when oral medications aren't good enough. We can actually go in and put steroid in next to the pinched nerves to decrease inflammation, helping with the pain again, so that you can do the physical therapy that is really important. Other people are responsive to things like aquatherapy for desensitization. You can use like yoga, Pilates for mobilization and strength training. There's evidence even for traction decompression, chiropractics, manual massage, TENS units. There's a lot of different conservative and augmentative options for people, which is great. So there's a lot of things to try. And since everybody is unique, it's really just about finding out what works for you.
Okay. All right. Very helpful. Thank you. All right. Moving along here, Dr. Harp, we will turn back to you. Can you talk to us about tech neck? What is it? And what can people do to prevent getting it? And I think you're on mute.
Sorry, it's the first time I've ever been on a Zoom. So, it's funny. I just wrote an article about this, and there's certain things in your life you should never write articles about, and one of them is tech neck. Uh, Tech neck is very interesting. It's probably something we've evolved to because we all have very poor posture. And so if you think about the average head weighs between 15 and 20 pounds. The interesting thing is that and I'm going to torture people, and if you're not a math major, put earmuffs on because it goes something like this. Remember those things we did in high school called vectors? So if you have your head like this, and we talk a lot in neurosurgery about what we call sagittal balance. And I'm not going to go too into detail, but essentially you have a pelvis, which is your pedestal at the bottom, and you keep your head above that. And your neck muscles are really just simple rubber bands. So if your head is above your pelvis, everything's in line, and those rubber bands don't have to work that far. The problem is if you go to the subway, walk down the streets of Philadelphia, you're going to notice, and I'm going to do this for everyone. This is how everyone looks at their phone. And when you take your head and you put your head down, your muscles are at very big disadvantage. And so what happens is when you look at the vectors by that, you're actually taking that 20 pounds of weight you normally have and you're putting up to about 40 to 60 pounds of forces onto your muscles. And so your body's not built for that. Now, I will tell you the group of population that's really prone to this are two. One is younger people because their necks aren't built, are very, they have little muscles on their neck. And the second thing is women tend to have longer necks and they have skinnier necks, which means that they don't have as much muscle mass to help them. And so the classic thing just to carry around tech neck is whiplash tends to be a disease that we see very common in women with long necks after car accidents. Very rare to see a football player come in with neck muscle problems. And so Dr. Nee probably will agree with me is the best thing you can do for your neck is build up your muscle strengths. The second best thing you can do is when you try to have the best posture, and I crack up because Dr. Nee, you have the greatest posture. I'm so proud of you. I'm like slouched over, dead at the end of the day. Dan Franco's given up. Sarah, you also have posture, great posture, and you two are great. So work on your posture, build your neck muscles. We call them your extensors. The stronger your extensors are in your neck and in your low back, probably going to correlate with the better chance of not having back problems and not seeing me, Dr. Franco, or Dr. Nee.
Okay. All right. It's something that I haven't heard of before, so very interesting. Thank you. Okay, moving along here, Dr. Franco Martinez, you are up next for us. Next question, what surgical treatments are recommended for cervical spine problems that cause radiating pain?
Okay. Before I go on with that, I just want to say I have a terrible case of tech neck right now. Like it really hurts. It's like I'm like this all the time, like Dr. Harris saying. It's so bad. It should be called like surgeon's neck or something, right? Because we do all this stuff with our phones and all that, and then on top of that, all of our surgeries were like this. And so it's so bad that now there's companies that are designing surgical loops that have like a 90-degree angle, and so you can operate just looking straight forward, even though your patient's below, but it's a bit hard to get used to though. But yeah, it's a real issue. So anyway, yeah, just to go back to your question, um, yeah, when someone has a problem in their cervical spine, your neck, sometimes, like I said before, nerves can be pinched or irritated, and that means oftentimes the pain will travel down your arms depending on which nerve is irritated. We can usually, depending on the distribution of your pain and how you describe it, we can narrow down to a potential level in your cervical spine, because even though the nerves are they usually have cross coverage. There's a certain pattern of pain, numbness, things like that. I can point you in a certain direction. And then we correlate that with whatever MRI findings we see and kind of determine what the next steps are. Um, Again, even with your neck, similar to your lumbar spine, you want to try things short of surgery before getting to even a surgical discussion. If medications, physical therapy, and injections don't bring enough relief, then we start to think about different surgical options. And the goal surgery is simple. It's just to take the pressure off the nerve and stabilize or preserve the normal function of the spine. And so the few main approaches we use can be number one of the very common surgeries, an anterior cervical discectomy and fusion, where we make a small incision in the front of your neck. We use natural planes where we don't have to cut any muscles or anything like that, and get to the area that we've identified is problematic, remove the whole disc, which endpoint should decompress the nerve that's all pinched off, replace the disc with usually some form of static implants. They come, made from a special type of plastic. Now the newer ones are made of 3D printed titanium, and there's also cadaver bone options that work really well, and it integrates with your body without issues. And normally after that, we put a little plate and screws to hold it in place. Um, we can do these at one level or multiple levels depending on the need. Um, Similar to the anterior cervical discectomy and fusion, there's also an artificial disc replacement, which the big difference between the two is that once the nerve is decompressed, is the type of implant that you place. The traditional implant is the static implant, the fusion implant, and then these newer um, implants are supposed to preserve the motion, the normal motion in your neck, and therefore hopefully prevent issues further down the line. So that's a different option. It's called an artificial disc replacement. Similar, not everyone's a candidate for that. Usually we reserve these for younger people with not a lot of arthritis that, perhaps have their symptoms caused by soft disc herniation and not a lot of bone spurs and things like that. So it's a good option, but it should be done for the right patient. And then there's also perhaps posterior cervical foraminotomies, which means basically decompressing the nerve, but from the back. Not necessarily requires a fusion, although we can do a fusion if it requires a more extensive decompression, but that is, a different approach. We come from the back of the neck instead of the front. Um, and we carefully remove a small amount of bone or tissue around the nerve and create more space to relieve pressure. I mean, this, regardless of whatever approach we use, the goal is almost always the same, which is just take the pressure off. Um, each of these surgeries has a slightly different recovery process, but most patients go home either the same day or the next morning. People are usually, walking straight away, and the arm pain tends to improve relatively quickly. Although it's hard, again, like I said before, it's hard to predict exactly how long it's going to take. And the rule of thumb is that if you've had symptoms for a long time, it's likely going to take a little bit longer to recover from. Um, in short, when neck problems cause radiating arm pain, surgery is about freeing up that nerve and helping patients get back to a normal life without pain. And then the specific type of surgery depends on the exact cost, location, and patient's overall spine health.
Okay. All right. Thank you so much. Appreciate it. Before we go to the next question here, I just want to remind people, if you have any questions that are popping up for you during this discussion, feel free to enter them into the chat. I see Dr. Harrop is responding to a few, but we'll also get to them live at the end that we can talk through once we get through our submitted questions. So thank you all. All right. But for now, we will move on to our next question here. Dr. Harrop, this one is for you. I know we've mentioned steroid injections previously, but can you talk a little bit about whether steroid injections can be used as a temporary solution for spinal stenosis?
All right. So here it goes. And there's huge controversy on this and very interesting. I'd love to get Dr. Knee's point on this. My general philosophy in life is any day you stay away from me and Dr. Franco is a victory. And so when I see patients for the first time, I am a total advocate um, for a steroid injection. Now it's interesting because patients will come to me and they're like, and particularly if you're an engineer out there, I'll tell you right now, you're the bane of my existence, but I still love you. Engineers are very black and white, and everything in medicine is gray. But what happens is they go, well, Dr. Harrop, you're going to give me a steroid injection, but I'm going to still have the stenosis there. And I'm like, true. But 3 weeks ago, before you had your pain, you had the exact same amount of stenosis there. And so my belief is stenosis is there. And if you look at people, and I'll just say right now, we know 25% of people over 65 in the cervical spine have stenosis, but you only need to treat if it's becoming a problem. And so I'm going to tell everyone a story because I love stories. And Dr. Nee's about to fall asleep, so I have to give her a story. So what happens is my best friend, who's a neurosurgeon, sends me to his dad, sends me, and he is a engineer. And so he has the worst spinal stenosis I've ever seen in my life. So get him all set up for surgery. We send him to pre-op clearance, and they're like, dude, your heart is like 900% blocked. It's more blocked than anyone else in the world. So goes to CT surgery, gets his heart done. They revascularize his heart, comes back after the heart surgery, all is good. Dr. Harrop, I'm ready for surgery. And I look at him, how you doing? I have no pain. And I'm like, I'm not operating on you. And he goes, yeah, but my stenosis is there. You got to operate on my stenosis. And I'm like, and he's ready. We're almost getting a fight in the office. And I'm like, I'm not operating on you. You're asymptomatic. And Dan Franco, how many years ago was that?
I'm sorry, repeat the question.
It's not really a hard question. You weren't paying attention, so I was picking on you.
It was not.
Actually, that was about 15 to 20 years ago, you believe it or not. The guy has never come back, never had, and I can tell you right now, if I got an MRI on him, most of us would vomit because it's got so much bad stenosis there. Treat the patient, you don't treat the MRI. That's the adage I've gone with in my life. And, I think so. Most of the patients, I see a lot of second, third opinions, and patients are like, I'm ready for surgery. I want to do it. And I'm like, try an injection. Because if you get your best chance with an injection is your first injection. And some people hit a home run. So I'm like, I think when you look at risk benefits to me, I would try an injection rather than try surgery.
Okay. All right. I guess a
By the way,
follow-up
but my chairman of my department just called me. He's going to murder me because I just told you guys not to have surgery. Sorry.
question. We appreciate it. No, I guess a follow-up question here before I know we're not going to get to our live questions yet, but I did see one pop up, which I think is a nice
Uh,
follow-up. I know someone
keep
asked if there are safe
keep on
numbers.
asking the questions because I'm a really quick typer, so I'm trying to answer everyone's questions, and you can ask follow-up questions if you want.
Amazing. Thank you. Um, if you can address this one for us, is there a safe number of steroid injections that one can
No.
receive in a year or a lifetime? I
I
think that
actually
might.
I'm typing the answer to that one too.
Here we go.
So here's a great thing. Do you know why, Dr. Franco? Now you're paying attention. You've got good posture. I'm so proud of you. Do you know why you get three injections for Medicare a year? I bet you Dr. Nee
I
doesn't
used to
even
know
know.
the answer to that, but I don't remember. But there is a very specific answer to that.
Okay. Here's but
There's a story
here,
behind it. I remember.
here's I'm trying to keep it a little light for the whole audience.
Yeah.
It's very interesting. So, and this was told to me, and it could be a complete lie, but it's a great story. In the old days, they didn't use fluoroscopy, right? So when they started doing it, they would give an injection, and the rate of a successful injection was 1 out of 3. So they figured if I gave you 3 injections and you got no relief, you weren't going to get any relief and you should have surgery. And so that is unfortunately a lot of things in medicines have gotten carried down to the years. The problem, and Dr. Nee, I'm going to defer to you on this one because my understanding is Medicare will pay for 3 injections a year. Although I will tell you, we've been able to get in certain circumstances for some patients more than that a year. But typically, most people will do 3 a year based on Medicare guidelines.
I actually hadn't heard that specific guideline specifically for Medicare, because we tell patients that you can have a steroid injection every 3 months very
Yep.
safely. And then obviously it depends on, if you're getting it in your neck and then your low back and then your shoulder and your hip and your knee. It is a little bit cumulative in terms of the overall steroid burden on someone. So we always try to keep that in mind too, trying to reduce the side effects.
Okay. All right. Well, thank you both. Dr. Nee, we will turn to you next for our next question here. Are there any medical treatments or research approaches for reversing permanent nerve damage?
Sure. And I'm guessing that the person who asked this may or may not have some experience with nerve damage. But for those people who don't, there is a spectrum of nerve damage. So there's sort of lighter nerve damage that's reversible, more moderate things that you can get some things back and some things not. And then there's what we consider more permanent nerve damage, where the nerve has degenerated and died. And there's, emergent research with treatments for symptom management, like there's repetitive peripheral magnetic stimulation. There's also nerve hydrodissection. Those things, when paired with physical therapy, have been shown to there's been evidence starting to show that it can be helpful for symptom management, but it's not really dedicated to regeneration because, quite honestly, there's not a lot of good data right now in human trials and clinical trials to show that we can regenerate nerves very well. So there's preclinical trials in labs and in animals that show stem cells, growth factors, and gene therapy that can be helpful with regenerating nerves. But unfortunately, the human clinical trial data just isn't there yet. I do know there's at least one institution out there that's looking at specifically spinal cord injury patients, where maybe we think of them as like paralyzed patients, right? Um, and they're looking at the feasibility of using targeted spinal cord stimulation to basically regenerate function, but that's still in its very early stages of like feasibility testing. Like, can we even do this on a cadaver model? So, unfortunately, the answer is not too uplifting.
Okay. All right.
Can,
Well, yes.
Sir, can I interrupt for 1 second? There's a type in the thing, and I just want to make sure no one's having a technical issue. I hear everyone's volume great, but there was one comment that the volume was too low. I think
Yeah, I saw that too.
one individual might have a volume problem, so see if you can turn up your volume. If other people are having a problem technically, please send us an email and we'll try to adjust.
Yes.
Sorry.
Yes. Thank you for flagging that. Yeah, if there's any issues, let us know, but I think we should be all set on our end. Okay. All right, we're going to go ahead to the next question here, Dr. Franco Martinez. What are the best ways to relieve headaches that originate from neck pain?
Okay, thank you. Yeah, a lot of people don't realize that headaches can actually come from the neck. We call these cervicogenic headaches, and they're surprisingly common. Uh, the nerves in the upper part of your neck, especially in the top three levels, share connections with the nerves that feel pain in your head and face. So if the joints or muscles in that area get irritated, tight, inflamed, the pain can travel upward and feel like a headache. Now, the first step in dealing with this kind of headache is figuring out what's causing it. And in some cases, it can be challenging. It could be as simple as poor posture, as we were describing, earlier. For example, sitting on a computer like we are right now, or looking down at your phone for long hours, or doing a lot of surgery. Um, or it could be due to arthritis or even a disc problem in your upper neck. Once we can hone down on the source, we can treat it directly rather than just masking the pain. The good news is that most of the time we can manage these headaches without surgery. We have a very extensive multidisciplinary team at Jefferson that involves us as surgeons, PMR doctors such as Dr. Nee, other pain specialists, and even headache neurologists if necessary. So we certainly have the whole breadth of multidisciplinary approach to this type of situation. Um, but in general terms, one of the most effective treatment can be just physical therapy. A good therapist can teach you exercises to strengthen the deep muscles of your neck, improve flexibility, and fix posture issues that put extra stress on those joints. Even small improvements in posture can make a big difference in reducing pain. And there's a whole slew of medications like anti-inflammatories that can help things cool down. And in more stubborn cases, there's certain types of targeted injections, such as facet joint blocks, occipital nerve blocks, trigger point injections, and epidural injections, depending on the specific case. All of these can reduce inflammation and sort of reset the pain cycle, and then giving therapy a better chance of working more effectively.
Okay. All right.
Can
Yes.
I answer a question, Sarah? Because someone asked a question I thought was a great question. Um, they said that they had a back problem and then the back problem caused the leg problem. And I find this fascinating. And this is something we probably evolved in the last 20 to 30 years to better understand. And I've seen it a lot in my practice, and Dan probably is too, is the whole world is connected. And so what typically happens is if you have a back problem is, and I'm going to go through evolution really quickly. And if you remember when you had a baby, the first thing they did is about 6 weeks, they start looking up and they start taking their head. That's when they develop their cervical lordosis, which is kind of cool because you're born kyphotic, born like a letter C. Then the second cool thing is about 9 months of age or 12 months of age, your kid starts running or getting up. Do you remember them getting up? Because if you know a little bit about spine, it's hilarious. because they look like an orangutan. And in order to walk, what they have to do is they have to put their hands above their head. And what they're doing is they're trying to throw a lumbar lordosis because what happens is they're so flat or their spine is so flat, they can't walk because they're so out of balance, they fall over. So they build a lumbar lordosis. Now it goes back to this common thing we were saying is you got to keep your head above your pelvis. Now, if you get in a trauma and you break your back, most of the times people do is they get kyphosis or you bend forward, right? Because you get in a car accident, you bend forward. Or the classic thing I see a lot is little old ladies that get compression fractures. So I'm going to step out for 1 second. Every person should get a DEXA scan. Once you're over 65 years old, every 2 years, get a DEXA scan. If you have a compression fracture, it needs to be treated because you have a 30% chance of having another compression fracture within a year. That's my biggest bane of my existence. And I'm like, I see all these people and they come in too late. So if you don't have a DEXA scan within the last 2 years, your job assignment is write it down, is to see your family doctor. And listen, if you can't get one, Dan Franco will see you and write you for a DEXA scan. Uh,
I will certainly order the DEXA scan.
yeah.
That's a great input.
But actually, seriously, any of the Jefferson doctors will see you. I'm more happy to see you to help facilitate that because I really think that's a general thing that we all need to do. But anyways, go back to this thing. If you break your lumbar spine, what do? You lean forward, right? Either it's from a compression fracture, no matter what it's from. So what you have to do is because society is built horizontal, is you need to crank your neck back in order to see. And what does that do? It causes you to have more neck pain. And so it's very interesting. So Dan Franco gets the most improved today with his posture because he's working so well on his posture throughout the thing. I'm so proud of you, Dan.
Thank-
Someone asked that question. I thought it was a great question. It ties together a lot. We have a short time to say this, but I'm trying to get big pictures out to people.
Yeah, absolutely. No, thank you for bringing that up. And I think honestly, now is a great time to maybe segue into our live questions. So let's go ahead and just run through them. But appreciate the reminder of the DEXA scan. So a great takeaway from today. Thank you. Okay, so I'm going to go ahead and just run through the live questions. Dr. Harrop, I know that you've responded to a few already, but I think it'll be great to just chat through live so other people can hear the discussion. So with that, I'll go ahead, run through them. Whoever wants to chime in, feel free. It'll definitely be an open discussion. And as more questions come up for you all, please feel free to submit in our chat. Okay, so for our first question from our live questions tonight, this question here, for severe spinal stenosis, are there pros and cons of a dorsal spine stimulator versus a laminectomy? And I know, Dr. Harrop, I believe you already responded to that in the chat, but if you could just talk through quickly, I think that would be helpful for our audience.
Okay, so really breakdown. I am a huge proponent and fan of spinal cord stimulators. Now, with that said, is typically our algorithm goes something like this, and we are very lucky. We have one of the largest neuromodulation centers in the country. Neuromodulation is electronic stimulation or trying to help the nervous system through other ways. We have 5 surgeons that actually do a lot of neuromodulation, that are neurosurgeons that are very interested and dedicated to this. And what they've taught me is this, is compression and mechanical pain do not work very well with spinal cord stimulators. And the two other areas that don't work very well is MS and spinal cord injury type of pain because you need neurons. And I'm going to go really quickly through anatomy. The way neuropathic pain, and I'm sort of going around this round, but just go with me, is I touch my finger. My finger goes, oh, I feel sensation. I get the signal, goes up my arm to my spinal cord, synapses goes to my brain. So I go, okay, that's normal. Now, what happens in neuropathic pain is you get in a car accident, you do something, you injure the nerves. Okay. I touch my finger, goes up my spine, goes to the area where the injury was. Now it gets confused. And so it's sort of just think of your computer. So now all of a sudden the signals aren't going in a straight line, you're getting cross signals. It goes to your brain. And what does your brain say? Oh my God, you have burning gasoline on your hand. And so a lot of the things that we've evolved over the last 10 to 15 years is I believe the best thing for neuropathic pain is is behavioral and desensitization techniques for the neuropathic pain. However, with that said, spinal cord stimulators work fantastic for neuropathic type of pain, diabetic neuropathy type of pain, those types of pains it works great for. Sciatica, in the sense of I have an electric pain shooting down my leg, it doesn't work as well for that. So you really have to step back. And here's the other take-home message for our people out today. You have to understand what your pain is coming from because all the treatments don't work. If you have neuropathic pain and I do a laminectomy on you, the only one who makes money or is happy is me because I get to put a bill on you and you're not going to get better. You need to be able to get a stimulator or something else in order to help you. So we spend a lot of time trying to figure out what's going on with you and where your pain is. I don't know if Dr. Nee wants to chime onto that or Dr. Franco.
Yeah, I mean, spinal cord stimulators can be an awesome tool for patients with pain. But like you said, it really depends on the situation. What is the anatomy showing us on the MRI? What are the complaints that we're trying to address? Unfortunately, there's not a magic bullet or a magic wand out there for us to use on you.
And, and the other thing, just to add on to that, which is great, is I think you need to get someone who has a plan in you. They invest time in you and they try things because the other thing that's evolved is we now have spinal cord stimulators that are percutaneous. And so someone can get a trial of a spinal cord stimulator. And every patient is an individual. You might have bad back pain. And the old thing in the old days is spinal cord stimulators didn't really work for back pain, but there's newer techniques. And so, if you're 18 years old and you have a problem, and you're 80 years old and you have the exact same problem, we're probably going to look at a different set of tools to try to help you.
Absolutely. Okay, thank you. That's great. All right, moving on to our next question here. Dr. Nee, I'm going to turn to you for this one. This person is wondering, how long should you try physical therapy before moving on to a new modality? Do you have any thoughts there?
Yeah, that's a great question. I think that physical therapy, first of all, I always tell my patients, you don't need to go multiple times a week, right? You don't need to be babysat. If you have, your working brain and you have the exercise papers that they give you, do the exercises at home, you get out what you put into it, and really give it a good try, meaning at least 6 weeks. Trying it, making sure you're doing it at home, making sure that your form is correct. You go back to them every other week, maybe every week, depending on how quickly you're progressing, how quickly the exercises become too easy, or if the exercises are hurting and they're making things worse. Do make sure that you go back to them, check it, make sure that things are, the correct form and whatnot. There was actually a question also in the chat about like McKenzie method specifically. So I know a lot of us are huge proponents of McKenzie method because it's a different way to approach physical therapy problems. So the physical therapist that is McKenzie certified, meaning that they went through all of the training, they approach problems a little bit differently than their colleagues in that they try to view problems in these buckets, and the way that you fall into the buckets then changes the exercises that they give you to actually try to help you self-regulate. So it's not just exercises to get strong and stretches to be more flexible. It's actually exercises to help you do things in ways that can actually address your pain concerns. So you can actually do them throughout the day, and it's not just, oh, let me do it for 20 minutes every night. And then to tie that also into another question that I was able to address, someone asked specifically about like what exercises can help. And I know Dr. Harrop was saying neck extension exercises. I do like to teach people like the most simple thing to do is to sit there and try to make a double chin. So turning to the side, doing this kind of movement, that's actually strengthening the muscles that pulls your neck backwards, which is the extension movement that Dr. Harrop was talking about. So really easy thing for you, me, anyone to do when we're sitting there is just to kind of scooch the neck back, push the chin in on yourself, make that really cute double chin, and that's actually strengthening those neck extensor muscles.
Okay, that's a great tip and something easy. Appreciate the model there. Very, very helpful. Okay, next question here, as I want to get through a few more before we wrap up for the evening. Uh, all right, I think Dr. Nee, this one might be for you, but whoever wants to chime in. What's your opinion on the decompression machines that are so prevalent at chiropractors nowadays?
It can be a helpful augmentative method when you tie it with physical therapy. So I know I sound like a broken record, but when you tie it with physical therapy, there is actually evidence in the research to show that decompressive traction, whether it's machines or when it's being done by a person like a chiropractor or a PT, it can be really helpful in the short term for short-term pain relief. The research is not as supportive in terms of like long-term pain benefits, but especially in the short term, when you're pairing it with physical therapy, that seems to be the sweet spot.
All right, thank you. Okay, next question here. I may point this to Dr. Franco Martinez. This person is wondering, can you please explain the difference between spinal stenosis and sciatica?
Sure. So one can cause the other is I think the short answer. So sciatica is, as we all know, the typical pain that people feel down the leg when one of the nerves in your lumbar spine is pinched off. Now, um, the term spinal stenosis or lumbar stenosis rather, basically what it means is narrowing in the spinal canal that uh, in turn causes pinching of the nerves. And so um, think of the spinal canal as a tube, and it has a certain caliber, and the nerves kind of flow through it and exit the spine on each side like a tree with its branches. And so the spinal stenosis is narrowing that primarily affects the tree trunk, right in the middle. Um, and so, like I said before, it can be caused by either disc herniations, arthritis, bone spurs, things like that. And depending specifically on where that pressure is, it may cause sciatica, but it may also cause back pain, or it may cause pain in a different distribution that may not necessarily be described as sciatica. But it can also, depending on the chronicity of the symptoms, can cause numbness and tingling as well. So, like I said before, it's one can cause the other in short, but I think that's the easiest way to answer that.
Yeah, thank you. Appreciate
I,
it. Yes.
I got two quick things I want to answer if it's all right. One of the questions someone asked was a very interesting question. They said, would you consider surgery on a patient who has a spondylolisthesis? And I'm sorry I talked so fast. Someone yelled at me before. Grade 1 and pain level 2 to 3, low back or not because of low back pain. So one of the things that we at Jefferson really do spend a lot of time is trying to understand your pain. And so one of the things that we've recently done is we started using what they call SPEC studies, which is a newer test where we use a radionuclear test and we merge it. It's a lot like it's like a PET scan to help us define where the pain is. And we work with the nuclear med people to help define that. But the question be this person, I'm sorry, not to be sexist, but degenerative spondylolisthesis is 8 to 1 women to men. And that's why I said she. Uh, is the question they're asking me is, should you have a surgery for this? Now, and I'm not going to get too much into the weeds here. That is probably one of the greatest questions in the world because it comes back to is what is your quality of life and what do you want? If I operate on you and your pain is a 10 and I get you to a 5, I get a Christmas card. If I operate on you and your pain's a 4 and I get it to a 5, you don't like me very much. And so I think that's really, really important when you meet with a surgeon or pain management or anyone is to get down to it. What is the goals of this operation and what should you do? And I will tell you for this individual, we actually make people do what they call patient reported outcomes. And I look at them every single time. And so the typical person with a degenerative spondy, and I am getting too much in the weeds here, is a 30. I'm just trying to throw these numbers out for you, is a 30. And typically you can get them 10 points better. And so why do I say that's important? Because if you come in my office and you're a 5, I can't get you 10 points better. And so are you going to get better from this operation? Unless you have a very specific problem, you're probably not going to do great with surgery. So it really goes back to the question of, do you and your surgeon have the same goals? And so make sure that if you're meeting with a surgeon or any physician, no matter what it is, ask them what is the goal of this operation, and are we going to be at the same place in 3 months from now? Sorry.
Nope, that's a really important question. I know you said there was two. Is there any other questions that you wanted to go through?
Me? No, I answered the other one when I said someone asked about a test, and I'm like, it's very interesting. They were asking, how do you do this? And I go, one of the things we do is to try to find your pain generator, is do this spec study. Because one of the things about Jefferson is, 50% of my surgeries are actually revisions. Um, and so I see a lot of people, and everyone's trying to do a good job, but sometimes you miss what people's problem is. And so we're kind of lucky is we see a lot of people that somehow may have got lost in the system. So we're more educated on what to look for. And so I use this spec study in a lot of people to try to find out what's going on. Not
Mhm.
always successful, but it's a good tool.
Mhm. Okay. All right. Thank you. All right. We have time for two more questions, and then we're going to wrap up with a final question that I have to end the evening. Okay. So while we have time, one other question here, and Dr. Nee, this might be for you. Are there any exercises that might help with tight neck and shoulder muscles?
Yeah, there's a lot of different exercises that you can do for tight muscles. I actually really also like to refer my patients not just to physical therapy, but if they have an interest in like yoga or Pilates, that can be a real game changer for a lot of people, just kind of lifestyle wise, because it works on both strength and flexibility, but doing it in motions. So it can be really safe to do. Also, for people who maybe are a little bit more mobility limited, you can actually do like chair yoga. There's a lot of different, more accessible ways to do things nowadays. Looking on YouTube is a great solution. In terms of like showing you specific exercises, I would refer you to a physical therapist to figure out more like, again, what are your problems, what are your concerns, and how do we address you as a person?
Absolutely. All right. A reminder to go talk to a PT. So thank you. Okay. Well, with that, I think we're just about time. So I would like to end this evening with one question for all of you. So that question is for the final question of the evening, what are your goals for everyone listening in on this webinar? I know, Dr. Harrop, we talked about the importance of setting goals. So what are your goals for tonight? What do you want our viewers to take away from tonight? So Dr. Harrop, we'll go ahead and start with you.
Okay, we're ready. Get a DEXA scan, number one, right?
I
Number
love
two is work on your posture, Dr. Franco. Number two is last thing person you should see is a surgeon, unless you have a cervical myelopathy. This is a different animal. Two is make sure your goals are the same as your surgeon. And three is always get another opinion.
Okay, that was pretty easy. Thank you. I think we can remember that.
I'm a simple guy.
All right, perfect. Well, thank you, Dr. Harrop. Dr. Franco Martinez, any goals that you would like our viewers to take away from tonight?
Yeah, I think my main goal for tonight is dual. I think education and empowerment. Spine problems can often sound scary. The terms like fusion, nerve compression, disc herniation can make people immediately think the worst. But the truth is, most spine conditions are very treatable, and with the right plan, people can get back to living full, active lives. I want everyone listening to walk away understanding a few key things. Back and neck pain are very common. They're not something you have to just live with, and there are many options, both surgical and non-surgical. Second, like Dr. Harrop has been saying, surgery is rarely the first step. Our goal as spine specialists is to help you get better with the least invasive approach as possible. Just because we're surgeons, we're not gonna, push you down that route if it's not the right thing for you. And third, knowledge is power. The more you understand about your spine, your condition, and your options, the better decisions you can make, and the better your results usually are. Um, so if you have any takeaways from tonight is spine health is manageable, recovery is possible, and small consistent steps towards better posture, movement, and care really do add up.
Okay. All right. Well, thank you. And last but not least, Dr. Nee.
Thanks, Sarah, and thank you, everybody. Thank you for all the participants who have called in. I know Dr. Harrop, Dr. Franco Martinez, and I have been furiously trying to answer questions in the chat as well. So I do apologize for all the people that we didn't get to address. But fortunately, I think we did put information on how to get scheduled for appointments somewhere. So I hope that you all at least learned something or multiple somethings. And I would say my goal for tonight is that everyone walks away feeling a little bit more empowered, a little bit more hopeful, and a little bit more enlightened, and feels like Jefferson Neurosurgery is really here for you.
Absolutely. Well, thank you. And yes, to reiterate that, thank you all for submitting such great questions. We know that we may have not gotten to all the questions tonight, but we appreciate the participation and your interest in education. So thank you. And thank you to the doctors, Dr. Harrop, Dr. Franco Martinez, and Dr. Nee. Such great information was shared, and I know we all learned a ton. So thank you. We will be posting an event survey, so you can let us know your thoughts. If there's any other specialties that you would like to hear from. If you would like someone to contact you directly to schedule an appointment with a Jefferson Health provider, you can go ahead and fill out the last question in the event survey. A recording of this event will also be sent to you, so you can rewatch at your convenience. That will be sent your way next week. And if there is anything anyone here at Jefferson can do for you in this time of need, please reach out to us. Thank you once again for joining, and please be sure to stay safe and healthy. Have a wonderful evening. Thank you.